Good afternoon, everybody, and welcome to this meeting of the NHS Commissioning Board. It's a very great pleasure to open the meeting and to welcome the members of the public who have joined us for the meeting today. To report, as always, that the Board, in pursuance of its determination to be open and transparent in the way in which it operates, has decided that it should meet in public and that our meetings will be webcast live. But of course it's not a public meeting, it is a meeting of the Board within a public domain. I should add, just for the elimination of any doubt, that the Board works also in developing policy very closely with the non-executive members and with the executive members. We have workshops, we have seminars, we've been working very closely together over recent months in preparing the strategy for the future of the Board. And that secondly, we, concurrently with this meeting, and on the same day normally, we'll have a private meeting in which we handle business which is confidential for reasons, for example, of personal confidentiality, or it comprises business that's still in the course of preparation to be brought to the main meeting of the Board. But our strong instinct is that this is a Board which is accountable to the population of England, and that it's appropriate that our work on behalf of patients should be undertaken in the gaze of the public and not behind closed doors. This is a new era for the NHS, and we're totally committed to the values of openness and transparency and putting the patient at the heart of everything that we do. Let me now turn then to the formal business. First, to confirm that there is no fire alarm due this afternoon, so that if the alarms do go off, we should leave the building in an orderly manner. Secondly, to report apologies from Kieran Devane, who has a conflict with his own Board meeting and isn't able to be with us today. Thirdly, to ask members of the Board if there are any conflicts of interest which they may hold in relation to any of the business on the agenda. And I will ask you to declare such a conflict when we reach that point on the agenda during the course of the meeting, if you wouldn't mind. We move now then into the formal part of the business, where we will take the minutes of the last meetings. There are two meetings: the 20th of September, which was the last meeting of the Commissioning Board Authority, and then the meeting of the 1st of October, which was the first meeting of the Commissioning Board, formally established by the 2012 legislation. And in the interim period from the 1st of October through to the 1st of April 2013, exercising some of its functions, particularly around the authorisation of clinical commissioning groups, and then from the 1st of April next year, exercising almost the full array of its new functions. May I ask colleagues, therefore, if there are any comments on the minutes of the last two meetings? Not otherwise. Okay, and any matters arising not otherwise on the agenda? No, thank you. Right. May I then move into agenda item 3, which is to invite Sir David Nicholson, the Chief Executive of the Board, to provide us with his report.
Okay, thanks, Chairman. And just to start off to talk about the wider transition that's going on at the moment in the NHS, the Commissioning Board and the commissioning system changes are one part of that, but of course there are other significant changes going on as well. And whereas we as a Board have started to take up some of our powers and responsibilities, some other parts of the system have now, at a national level, come onto the field. So, Health Education England, an organisation responsible for funding training and education, professional training and education across the country, with particularly significant responsibilities in relation to medical, nursing and allied health professional training. They are now starting to go through their planning process to get their resources and objectives right for this for next year as part of the planning process. The NHS Trust Development Authority, which has been set up to oversee the NHS Trust movement to foundation trust status and to performance manage the provider side, the non-foundation trust provider side of the NHS, are now up and running and taking their responsibilities and thinking about how they're going to take forward their their responsibilities for next year. So as you can see, the different parts of the system now are coming into place. And what's really important, and something that I think we learned the last time there was a series of changes in the NHS, is that it's not just the structural changes that you need to keep emphasis on. You need to think about the cultural and other changes that are happening as well. And one of the things that was started off by the previous Secretary of State was a series of discussions involving national bodies described around developing a common purpose. And those have continued after he went. Malcolm has hosted a couple of dinners to take things forward, and we're trying to develop a common purpose across all the national bodies, which I think is particularly important for the service as a whole. We need to be completely joined up in our kind of focus on the delivery of outcomes, the support and the promotion of the NHS constitution. The work around integration is all dependent on national bodies getting their act together, and I think this is a really important part of what we need to do. As part of that, the executive team here has had 2 meetings with the Department of Health executive team. We've had a meeting with the Care Quality Commission executive team, and a further set of discussions with the NHS Trust Development Authority, and we will continue to have those bilateral discussions with those organisations over the period to build the common purpose. I know the chairman's been involved in meetings with other bodies chairman across the country, and similarly I have as well. So we're trying in a very concrete and sensible way to build that common purpose. And indeed, as we know from our last meeting, Bill McCarthy and his team have been working on a series of partnership agreements between the board and the various parts of the NHS to kind of make sure that we are organised and we are concentrating on the future improvement of outcomes of patients. So I think that's all very positive, and I can see real benefits in the way that's happening. But for us in the commissioning board, of course, it's all becoming now much more real, in the sense as we take on our responsibilities and take on our powers, we're starting to do some really important things. And I don't need to remind members that if you take into account there are, I think, 97 working days between now and taking on our full powers. So really the pressure now on in terms of taking the organisation, taking the system forward is very much with us. An important part of that is the development of the mandate. This is in statute, and this is a document which sets out what the government's ambition is for the NHS, for the NHS Commissioning Board. It's the key bit, in a sense, of the relationship between the Department of Health and the Commissioning Board. It's due to be published soon. There's been lots and lots of discussions between ourselves and the department and ministers and other parts of the system to make sure that when it's published, it has the support of people across the system. I think a key thing for us in relation to the mandate is, if we're going to hold true to our determination to give more power and responsibility to frontline clinical staff and clinical teams and clinical commissioning groups in particular, it's very important that the mandate is an enabling document that enables us to do that. And discussions are ongoing, and we hope they'll come to a satisfactory conclusion relatively soon. In terms of clinical commissioning groups, we now have 211 clinical commissioning groups. Members will know that we discussed that we had 212 last time, 211. 2 have come together in Birmingham. They've all now entered the process of authorisation. Many people around this table, I know, will have been observers at those authorisation visits. It's very important, I think, for board members to get into the detail and understand all of that. As observers, we've obviously got a responsibility at the end of the process to do the authorisation and think about the conditions. But nevertheless, it's very important to do that. I've done a couple of the chairman's done a few people around the room, and it is a very interesting and I think quite inspiring set of arrangements. I visited one a couple of weeks ago where There are 2 or 3 things I thought which was very interesting in what they do. There's no doubt that clinical commissioning groups at their best can do things much quicker and much more in a patient-focused way than perhaps the old system ever could do. They gave 2 or 3 examples. They one where they have a GP. The GPs have on their computers a little bit of software which enables them to take feedback from patients about how they've experienced the service and also how they've experienced secondary care services. They bring all that information together so that they can talk to their secondary care colleagues about what's happening in a very kind of real-time basis, which I think is a really exciting and interesting way of getting, in a sense, patient views directly to the clinicians on the front line. They gave us an example that there are around the country things which are known in the jargon as virtual wards. These are groups of patients who we support in the community who would otherwise have been in hospital. It's very good for patients and it's very good for the staff. Very interesting set of arrangements. They went from a situation of having a meeting at the CCG saying they thought they needed a virtual ward to actually delivering it on the ground in 6 weeks. Again, I think a responsiveness I don't think we would have seen before. I think there are lots of examples like that as we go through, which I think truly show the potential for this new system to do great things for patients. But getting back to the commissioning board, the final thing that I would say, the next certainly 10 weeks or so are going to be particularly crucial for us as a board. We'll start some of the conversations today, but in the next 10 weeks or so, we're going to have to make allocations to CCG. So the setting out of the way in which we're going to give resources to CCG to take their services forward. We're going to have to, so all that work we need to do, and I think the December meeting is when we'll do that. We need to set out what our expectations are for the system as a whole, what perhaps used to be described as planning guidance, but I think much more is about how can we help the service take things forward, what are our expectations and what do we really need the service to do. So those kind of planning arrangements need to be set out. As part of that, we need to set out the commissioning outcomes framework, a very important part of the incentives in the system to make things change. And as part of that, the way in which we're going to deploy the quality premium, we're going to publish a new national contract, and of course we've got to finalise the discussions with the department around the tariff. So all of those major levers need to be brought together in a coherent way, in a way which really does show a connection between what we're trying to do and how we're doing it, so it can demonstrate patient focus and a commitment to outcomes as we take all of that forward. That's an enormous bit of work, and we're going to reflect, I guess, on some of that today. So I'll finish there.
Thank you very much, David. Any questions to David on that report? No. Well, thank you very much.